Welcome to the Wellness Protocol, your source for guidance on metabolic health, hormones, and longevity. I'm Dr. Alessia Roehnelt, double board certified endocrinologist, and on each episode, I'll share simple tools rooted in science and experience to help you feel better, live longer, and take control of your health. Welcome back, everyone. Today, we are going to be diving into a topic that affects approximately 1 in 10 women of reproductive age. And yet, it's often misunderstood, it's misdiagnosed, and many times, unfortunately, it's mistreated. We are talking about PCOS, or Polycystic Ovarian Syndrome. But let me just say this up front. PCOS is not just about irregular periods or having ovarian cysts. It's actually a very complex metabolic and hormonal condition. And it can affect your skin, it can affect your weight, your fertility, your mood, and cause some long-term health risks. So in this episode, we're going to break it all down. We will be talking about what PCOS really is and isn't, why it's not just a reproductive disorder, the role of insulin resistance and inflammation, how PCOS can affect fertility, mood, and even skin, and what treatments, both conventional and lifestyle, can actually work. All right, let's get started. So what is PCOS really? PCOS stands for Polycystic Ovarian Syndrome, and we call it a diagnosis of exclusion. What that means in the medical field is that we need to make sure your symptoms are not due to anything else. There are other medical conditions that can cause symptoms very similar to PCOS. So when you see your gynecologist, your primary care doctor, your endocrinologist, whoever is evaluating you for PCOS, they will need to rule out any other types of conditions that are similar. This can often be done with a very good medical history, in addition to certain types of blood tests, urine testing, possibly imaging tests as well. If you have been ruled out for everything else that could possibly cause your conditions, you also need to meet 2 out of 3 criteria. Those 3 criteria are either irregular menstrual cycles, and when I say that, I mean irregular cycles pretty much since you started to get a period. So many times the history for a patient with PCOS is that they started to menstruate or get their period around age 10, 11, 12, and it was never consistently regular. It would come every 6 months, once a year, every couple years, very, very inconsistent menstrual cycles, and usually from the beginning. The second is elevated testosterone levels on blood work or signs of elevated testosterone on physical exam. That could include things such as facial hair growth. It could include significant acne. So these are signs of high testosterone in the body. So you would need either a high level on a blood test or exam findings consistent with high testosterone. And the third is cysts on the ovaries. So what's interesting about that is we call this Polycystic Ovarian Syndrome, but you actually don't even need to have cysts to get this diagnosis. You only need 2 out of these 3 criteria. So many times we don't even move forward with getting an ovarian ultrasound because that information won't necessarily change the diagnosis in many patients. When I say cysts on the ovaries, though, we are talking about a specific type of pattern. We actually see a bunch of very tiny, tiny little cysts or follicles. We don't see these very large follicles that can rupture and be painful. It is just a lot of teeny little follicles. They are usually described as a string of pearls. You might see that term on an ultrasound report. And it basically means these teeny little cysts, about 2 to 9 millimeters in diameter, and they're arranged around the periphery of the ovary. Additionally, the ovaries themselves may appear large, but an ultrasound consistent with PCOS is not going to have large dominant cysts that could rupture. This is going to be just a lot of teeny little cysts. So again, to be diagnosed with PCOS, first, any other conditions need to be excluded. And second, you need to have 2 out of the 3 criteria I mentioned. Number 1, irregular menstrual cycles. Number 2, high testosterone. Or number 3, the typical small little follicles, but multiple follicles seen on ovarian ultrasound. Now, I think it's interesting that the metabolic consequences of PCOS are not really listed in the diagnostic criteria. What I mean by that is many women with PCOS also have a condition called insulin resistance. Insulin resistance is basically the first step towards developing high blood sugars and prediabetes, and then goes into diabetes. If you have insulin resistance, you have a very high risk of developing diabetes in the future. You have a high risk of having high blood sugars in pregnancy. And in patients with PCOS, I often find that there is not necessarily a strong family history of PCOS, but there is a strong family history of type 2 diabetes. So this insulin resistance component that goes along with PCOS is very strong. And it is one of the reasons why women with PCOS generally have a very difficult time losing weight, and they tend to gain weight very quickly. Because not only are they fighting these hormonal imbalances, they are also fighting these metabolic imbalances. And PCOS isn't just physical. There's also this very strong emotional and psychological component. Women with PCOS are known to be at higher risk for things like anxiety, depression, body image issues, or disordered eating. Some of it could be hormonal because high androgens or testosterone can actually affect brain chemistry. Also, insulin resistance and inflammation can definitely affect mood and energy levels. But much of it comes from years of just being either dismissed by family, friends, even healthcare providers. Potentially they have been misdiagnosed, or maybe they're struggling with symptoms like acne or facial hair growth, and it is really impacting their confidence. So let's go back to some of the conditions that we need to rule out when we meet a patient who potentially has PCOS. The first is thyroid disease, because an underactive thyroid or hypothyroidism can mimic some of the symptoms we see in PCOS. It could potentially affect menstrual cycles. It could potentially affect and cause weight gain. It can cause mood disorders. So we need to make sure that someone does not have any thyroid disease at play. We also need to check prolactin levels. There is a hormone called prolactin, which is made by the pituitary gland. The pituitary gland sits right behind your eyes, but in front of your brain, and it is one of your major endocrine organs. I oftentimes call it the command center for the hormones in your body. That pituitary gland makes the hormone to tell your thyroid how much hormone to make. It tells your ovaries how much estrogen to make. It tells your adrenal glands how much cortisol to make. So it is really the command center of the hormonal endocrine system. And there is one hormone in that region that if it's elevated, it can affect menstrual cycles. It can make them more irregular or suppress estrogen production. This hormone is called prolactin. It is supposed to be high in conditions such as pregnancy or nursing because it is also the hormone that allows the body to make milk. But if it is high for any reason, it could potentially impact hormone production. So that is a condition that needs to be ruled out as well. Much less commonly, there are some genetic conditions that can cause some of the symptoms similar to PCOS, such as late onset congenital adrenal hyperplasia or CAH. This can be tested for with certain blood work. And we also need to make sure that you don't have excessive amount of cortisol production or something called Cushing's syndrome or Cushing's disease. Again, this condition can present with similar findings to PCOS. Some of the lab tests that we might run as physicians could include an LH to FSH ratio. These are hormones made by that pituitary gland. And generally in women with PCOS, we will see that ratio of LH to FSH about 2-to-1 or even higher. But this is not one of the diagnostic criteria, and we certainly do not see it in every patient with PCOS. But it's certainly something that we look for. We definitely check testosterone levels, possibly free testosterone levels. We may check some of the adrenal hormones like DHEAS or 17-hydroxyprogesterone. I, as an endocrinologist, will always check fasting blood sugar, fasting insulin levels, hemoglobin A1C, and a cholesterol panel, because these numbers all relate to the metabolic health of the patient and look to find things such as insulin resistance. We may choose to do an ovarian ultrasound to see the pattern of the ovarian follicles, but as I mentioned before, because you do not have to have these ovarian follicles to meet diagnosis, we generally don't run this test. But as I mentioned before, you don't need to have that classic PCOS appearance to be diagnosed with PCOS, so oftentimes the ultrasound is unnecessary. So let's talk about ways to treat PCOS if you have been diagnosed with it. I cannot emphasize enough how important lifestyle modifications are with this diagnosis. Many women are diagnosed with PCOS in their teens or early 20s. This is a condition where if you start to make changes to your lifestyle early on, you can treat and prevent a lot of the possible medical conditions that may be associated with it. So number one, because many women with PCOS are insulin resistant, eating a low-carb diet is often very helpful. When women have insulin resistance, eating carbohydrates will cause insulin levels to spike, and insulin is a hormone of fat storage. So when you eat carbs and your insulin goes up, it's a signal to tell your body to hold on to fat and to store fat. Because of that, it becomes very difficult to lose weight if you are eating too many carbs. So number one, I encourage all of my patients to really switch to a lower carb diet. I don't recommend excluding things like fruits and vegetables and fiber and all of that. What I'm really talking about is a lot of sugars, a lot of sweets, or those starches that don't necessarily have a lot of nutritional value. Things such as bread or pasta. Making these changes and cutting out these food groups can really help with the weight loss process, and it can also help to prevent prediabetes and diabetes down the road. In PCOS, a lot of studies have shown that losing weight or being at a normal BMI or body mass index can allow the hormones to work a little bit better. So as physicians, we typically recommend patients try to lose weight with lifestyle modifications. Again, low carb diet, regular exercise. I'm talking several days a week, 5 days a week, maybe even 7, to really keep a healthy body weight. And sometimes that is enough to get women to have regular periods and to lower testosterone levels. Managing sleep is also really important here. Cortisol levels can impact insulin production, inflammation, and even ovulation. So prioritizing sleep is very important. There are actually many supplements on the market that are geared towards PCOS as well. I would caution you, as always, check with your individual physician about whether these supplements are a good idea or not for you. I personally love supplements when used in the right way, when used in conjunction with a good lifestyle adjustment or a very healthy diet. But they are not necessarily this magic pill that is going to make everything get better. So you really need to be cautious on which ones you do decide to use and have that conversation with your doctor. But one potential supplement that could affect and improve ovulation and could potentially help with pregnancy rates is a supplement called inositol, or sometimes it's given as myo-inositol. There is some evidence that this supplement can improve ovulation and insulin sensitivity. So that might be one supplement either your doctor recommends for you or that maybe a friend is recommending you wanted to try. But of course, always check with your personal physician first. And when we try the lifestyle modifications, and despite eating a low carb diet and despite regular exercise and regular sleep, women are struggling with this diagnosis. Perhaps they're struggling to get just regular periods. Perhaps they're struggling to get pregnant. Perhaps they're struggling with the rapid weight gain. There are medication options that we can use. Many of these medications are a Band-Aid on the problem. They are not going to reverse PCOS and make it go away. They are going to help control the symptoms that are most concerning at that particular time of life. Let's say a patient comes in and they are most concerned about the regularity of their period. They don't like that they never know when it's coming. It could be every 3 months. It could be every 6 months. They're not prepared for it. They want to feel like they're getting a period every month. They just want that regularity and to kind of be similar to their friends. That can be treated with an oral contraceptive pill or a birth control pill. Birth control pills can help reduce testosterone production, and they can help women get that regular menstrual bleed. You also, by giving a birth control pill, are assuring that that person is getting enough estrogen for their body, because estrogen is so important for bone health and cardiovascular health and brain health. So we want to make sure that women who are not getting a regular cycle are getting enough estrogen. And you can accomplish this by giving a birth control pill. Again, this is not reversing hormone production or changing anything about that person's body, big picture. But for the time that they're taking that birth control pill, we see adequate estrogen levels, lower testosterone levels, and regular periods. Sometimes by lowering the testosterone levels with a birth control pill, we can fix a lot of issues like bad acne that women might be getting, or increased hair growth on the face, chest, or back. But when giving these hormones is not enough to suppress testosterone enough, we can add on another medication called spironolactone. Interestingly, spironolactone is not a hormone. It was initially developed to treat high blood pressure, but it was found to block testosterone receptors. That means that any testosterone you're still making can't bind to the receptor, so it can't do as much damage to your body. This one can really help, again, with those testosterone symptoms like acne and bad hair growth. It does take time to work. Normally, we'll see effects on the skin in about 1 to 3 months and effects on hair in about 6 months. So it is something that you need to be patient with. But it could be a very good option for treating some of those high testosterone symptoms. It is not safe in pregnancy, so pregnancy needs to be avoided when taking spironolactone. Spironolactone can have a few side effects because it's a blood pressure medicine. It can sometimes make the blood pressure too low. So for women with low blood pressure, we sometimes can't use this medication. Your doctor should also be seeing you to monitor your potassium levels, because very rarely this medicine can raise potassium levels to a point where they're too high. So it does need monitoring, but it is another tool we can use to help with some of these PCOS symptoms. The third medication, which is always my favorite, is something called metformin. Metformin is a wonderful medication, in my opinion. It has been around for decades. It is generic, so we have access to it. Everybody has access to it, basically. And it can do a lot of great things for women with PCOS. It can potentially help with insulin sensitivity so that their bodies are more sensitive to insulin. This can help with things like weight loss, potentially. Not a lot of weight, but maybe a few pounds. Some women are very sensitive to metformin, and it does cause some weight loss. Oftentimes, women just feel less bloated when they take metformin. It can help prevent diabetes, or at least slow the progression of prediabetes into diabetes. And from a fertility perspective, it can actually help not only regulate menstrual cycles, but it can actually help with egg quality and pregnancy rates. So you may see this medication used in the reproductive endocrinology world for patients with PCOS. Or perhaps a patient is not worried about getting their period every month and they don't want a birth control pill. They're actually trying to get pregnant and they just want a period every month so they know they're ovulating. Well, metformin can be an excellent option for these patients. There are a significant amount of people, though, that cannot take metformin because they get stomach side effects with it, mostly diarrhea. So if you're a person where when you start metformin, maybe you feel a little queasy, I always tell my patients, try to keep going. That mild side effect should go away. But if you're one of those people where you start a low dose of metformin and you are running to the bathroom because it's really bothering your stomach, you probably should just stop it. It's not really agreeing with you. But metformin is an excellent choice for women with PCOS. And another medication group that is just starting to get some traction are the GLP-1 medications. So those are medications like Ozempic, Mounjaro, Zepbound, Wegovy, or the generic name for them, which is semaglutide or tirzepatide. These medications were initially developed to treat diabetes, then they were utilized for weight loss, but we are seeing really phenomenal improvements in women with PCOS as well. Again, PCOS, it's not just a hormonal condition. It really is a metabolic condition. So when you start to think about someone's metabolism and the hormones of insulin, liver function tests, heart health, when you take all of those together, medications like the GLP-1s can be very effective for treating. Now, unfortunately, we don't have any good data yet on pregnancy and these medications or nursing and these medications. So they generally cannot be used when someone is actively trying to get pregnant, but they are good options for women who are trying to keep the weight off, prevent other medical conditions, try to get their period naturally every month instead of with a birth control pill. The GLP-1s can be a good class to look at. And I think we'll just continue to see more and more data coming out on this. And one option I also want to mention when talking about PCOS is there is the option to do nothing medically. If you have PCOS, that does not mean you need a medication to treat it. When we're talking about PCOS, we are talking about symptoms. So if your menstrual cycles are maybe not that irregular, maybe you get one every couple months, and that doesn't bother you, you don't need to be on a birth control pill. If you don't have any of the physical signs of high testosterone, or perhaps those signs like the acne or the hair, it doesn't bother you, you don't need to be on spironolactone. If you don't have any signs of insulin resistance or prediabetes, you don't have to be on metformin. So none of these are medications that have to be used. They are just options for women who are struggling with PCOS or who are not able to control their symptoms through lifestyle modifications and weight loss. But patients with PCOS should also consider the long game and why making adjustments to your lifestyle or using a medication could really make a difference long term. So as I mentioned before, if you have PCOS and are found to be insulin resistant, you have a very high chance of developing blood sugar issues down the road, such as gestational diabetes or type 2 diabetes. You are also at a higher risk potentially of cardiovascular disease. If you're a woman who is not getting their menstrual cycle at least every 3 months, then you may even be at a higher risk of endometrial cancer because your body might be building up a uterine lining, but never getting that signal to shed the uterine lining. So if your periods are very irregular or completely absent, you could be at a higher risk of uterine disease. So treatment isn't necessarily just about fertility, trying to get pregnant, or physical appearance. It really is thinking about long-term management. So not that medications are needed long-term, but certainly making those lifestyle adjustments at a younger age and continuing them through your life is so important for staying healthy long-term. So PCOS is a hormonal condition, but also a metabolic condition. PCOS is very common. We are seeing more and more of it as the years go on. And there are these tools and strategies that can not only help you feel better, but they can help you live longer. And I want to encourage any patients with PCOS who are listening to make sure they have seen an endocrinologist for a metabolic evaluation. Since this is not just a hormonal condition, it is important to get that perspective on how to optimize your metabolic health in addition to your hormonal health. If you found this episode helpful, please share it with a friend or family member, leave me a review, or subscribe to the podcast so that you never miss an upcoming episode. Until next time, I'm Dr. Alessia Roehnelt, and this is the Wellness Protocol.